Hello, afternoon, morning, or evening, wherever you're listening to this. This is Matthew Holt. I am the founder of the Healthcare Blog and the sort of head honcho of the THCB gang. It's that time again. Once a week we get together and chat about all things healthcare, or sometimes not all things healthcare, depending. But I think this week we're going to talk a lot about healthcare because we have a couple of special guests. Who do I have with me today? THCB regulars Kim Bellard, regular writer and contributor, health futurist Ian Morrison. Back for a couple of second time in recent weeks because she's been in Europe, my old friend Jane Sarasohn-Kahn from Think Health, and somebody who's not on enough and should be on more, Robin Farmanfarmaian, author of Patient CEO, Patient and Healthcare Entrepreneur. All right, and special guests this week are Bob Revitzer, a longtime industry consultant with Accenture, at United now, I think at Manat these days, Bob, and his brother Jim. I don't know if you guys are twins or not, but you certainly look enough alike.
We are.
You are? Okay, well, that fools us. And Jim is a professor of business at Boston University. And most importantly for this, they just wrote a book, which is out. I think you can now go buy it on Amazon as of today or yesterday or very recently, about healthcare, called Why Not Better and Cheaper? So we're going to start this by going around the gang. I'm going to start with Robin and ask for what have you been looking at the last couple of weeks? What's you been doing, and is it going to make healthcare better and cheaper, or is it the opposite? So I'll start with you, Robin.
So I've been back and forth to Boston all year, and I gave a keynote at a consulting company called AMS, Advanced Medical Solutions, and they work with stop-loss insurers as well as like big employers on finding those patients that are costing the most amount of money and really helping reduce those kinds of costs. So it's been really exciting in my world between all my keynotes for things like Bioformis, which also reduces the cost of being a patient. And I just joined the advisory council for ARPA-H. And so there's a 12-person advisory council, and we're going to try and figure out where to spend $1 billion in the healthcare system.
Wow. $20 billion should lower the cost anyway. Well, so Robin, you are actually going to blame yourself if healthcare is not cheaper and better, very shortly. All right. Kim, let me go to you next.
Well, we've talked in the previous ones about how states are actively deciding they want to practice medicine. I just saw that Wisconsin has blocked an effort by the governor to require meningitis vaccines for 7th graders. They've also made it easier for parents to opt out of chickenpox vaccines. Iowa has joined what I now understand to be 48 other states in allowing raw milk to be sold without being pasteurized. So there are things that we know work, and yet the states are actively fighting to keep us from the things that we've discovered with modern science that can keep us better.
And possibly cheaper. So I think a case of meningitis is it's just more expensive than a few vaccines were. Jane.
Yeah. So on both sides of the pond, I've been spending a lot of time on the issue of food and nutrition in retail health. And I'd love to chat with the Rebitzers later on the patient as the payer, because with the patient spending more out of pocket, he is looking at food much more seriously in the pandemic and since. So I noticed in JAMA this week, there's a great piece on food prescriptions, which I love seeing. And then on the more tech end of things, watching Abbott collaborating with Weight Watchers and the ADA, the Diabetes Association. And we're, of course, can talk later about drugs and like Ozempic, and which I keep wanting to sing the song of, which is terrible. It's such an earworm. But this issue of food and retail health has got me busy right now.
Brilliant. Ian.
Well, I spent last week a couple of days at a retreat with the doctors' companies, one of the leading malpractice insurers, and they're always interesting to learn from. And spent a good deal of time with Jim Bajian. I don't know if you've ever run into Jim, is my favorite astronaut, but he ran sort of patient safety for the VA when the VA was the leader in patient safety back in the turn of the century, and he was also sort of deeply involved in making aerospace safer. Anyway, but most of all, and then I had Mohs surgery, hence the hat. I'm not being disrespectful. That's a good juxtaposition. The Mohs surgery all worked out. But then I was speed reading the Rebitzer book. I've known Bob forever, and Jim, it's great to meet you, however, virtually. But Bob and I are good pals. But I actually thought it was a great dissection of the theory and practical side of why we don't actually get better, faster, cheaper. And I'd throw out a couple of examples that just came across the transom today. I mean, I had a call earlier with 3 CEOs talking about transformation that we're going to do at the American Hospital Association in a week. And they're grappling with all the things we talk about here, the chat GPT. How do I make it fit in? How do I absorb these technologies appropriately without getting distracted by shiny objects? So I think we should talk about their world that Bob, you and Jim know well, but that we all kind of have to work through. The other example that crossed the transom this morning was Bright, who had a $10 billion valuation when it came out, just sold the rubble of what's left of it to Molina.
Right.
And I hate to say I told you so, but I think many of us were skeptical that the world doesn't need another insurance company, especially one with 150% medical loss ratio. But anyway, I'd love to hear their comments on all of that and above. But I think the book's a great contribution. What's the past tense of speed read? I did that, but so recall. Don't ask tough questions, Rebitzer, because you probably failed miserably.
Fantastic. Well, I don't know about you. You've all been working far too hard. It's July the 4th. So as a good American, I finally did it this week. I achieved the American dream of water skiing and snow skiing on the same day. And I've got to tell you, both of those, a bunch of old men water skiing, I fell, hit my head quite hard on the water, then felt, there's a good photo of me wiping out. You can find on Twitter. But then I went to the 4th of July sort of ski party and met a whole bunch of Americans who were skiing and having a lot of fun in the sun. And I would say were not particularly sober. In fact, the family I got on the ski lift with, one of the 3 times I went up, we're all passing the mother, who was a little younger than me, was passing little mini bottles of Fireball whiskey to her kids, and then said, "I don't do this drinking and skiing thing." As she took out her vape pipe and choked up. My wife took one run and said, "This is too scary. Everyone, I'm sober, everyone else is drunk." But I had a lot of fun. But the future healthcare costs of that endeavor will be quite, I'm sure, will be quite high. So that's the America that we're dealing with, and that may be one reason why it's not better and cheaper. But Bob, Jim, why don't you give us the 3 main tenets? You start off talking about financial incentives, then you move into some professional norms and narratives and innovation. So for those who haven't read the book, which is probably almost everyone listening to this because it's barely out, give us a quick the flavor of the argument, and then we'll dive in as to whether any of these examples are going to help or not.
Jim, do you want to go, or do you want me to go? We, as twins, we have to be very careful about being who goes first. After you, Alphonse.
He's got to be careful. Yeah, sure, I'll go. So, first off, thank you very much for having us on. It's really a pleasure having written the book and having written the book with my brother. And now it's like your kid's grown up and he's got to go out and fend for himself. So now we'll see how the book fends for itself. The book focuses around a question that Bob and I have been discussing for many years, which is, why doesn't, if the cell phones in our pockets can get cheaper and better, why doesn't healthcare? And it's built on the same sort of fabulous technological foundation. Why doesn't it happen? And that's what we began wrestling with many years ago, and from my perspective as an economist who studies healthcare organizations and decisions, and Bob's as somebody who actually helps organizations do their job better. And we ended up learning a lot from each other about how to do it. The short story of our answer to the question is that, and it is kind of, if you think about it, kind of odd. Right, we sort of say this profusely innovative area, this hugely innovative area, is generating the wrong stuff. It's generating the wrong stuff, and it could be generating much better stuff, that's both better and cheaper. And the question is why. And we organized, our answer is because on one level is very simple, and at another level is kind of deep and hard, right? The simple level is that it's too easy to make money from mediocre innovations in healthcare, so you get a lot of them. And it's too hard to make money from cost-reducing innovations, so you don't get enough of them. But the question now, why is that? Why is this a world where that's the case? That gets kind of hard. And we organize our answer around three things, two of which economists like me like to talk about. And the third is something that economists like me are just learning how to talk about. And so the first has to do with incentives and misaligned incentives. The second story has to do with social norms and narratives, which are terribly important in innovation. And the third has to do with competition and how competition is regulated in these markets. And so then we spend a lot of time sort of trying to figure out why is it that this combination of incentives, norms, and competition produces this sort of weird result in the health sector that you don't necessarily see elsewhere in the economy. Did I get that right, Bob?
You got it.
Okay.
You got it. So the thing, this book really began, it's Jim's fault.
I bet that's the first thing he's ever blamed you for as a twin brother, ever.
Yeah, it's really his fault. I once said to him, I said, boy, it's a shame nobody can make money reducing costs in healthcare. And he said, wait a minute, that doesn't make any sense. And that's where the book began. So it's his fault.
Yeah.
So,
you're working for a client, right?
Yeah. Oh, so on that point, right, I was reading actually this very newsletter from a guy called Benedict Evans, who's a sort of advertising media guy. Anyway, this week's just happened to pick up. He was talking about the issue of the British Navy in 1900 had mentioned the steamship, and that and so the forecasters figured out that there was a debate between are steamships going to run out of coal because demand for coal would increase so dramatically, or the steam engine is going to get better so much more quickly that they don't need as much coal. And the answer turns out to be the engines got better and cheaper and didn't need as much coal. But because it was better and cheaper, you could buy more warships. Right. So then the Navy increased. We seem to be, that is kind of how it seems to be the most quote unquote rational markets evolve. I think about the cell phone. I mean, yeah, the cell phones got better and cheaper, but we're all paying $200 a month or whatever, $40 a month for, plus our internet cable. We're buying a lot of stuff we didn't have 30 years ago because there was no cell phone bill, and yes, it doesn't cost $1 a minute to call Australia or whatever it used to be, but there are costs and obviously benefits that are aligned with that. So on the competition side that you guys feature, and I'll start with questions and then else can pile in. What's wrong with healthcare competitions? And is this all about evil drug companies patenting drugs and stopping substitutes come on the market by legal subterfuge, or what's the big picture with what's wrong with competition?
Before we go, but I'm going to leave my brother to talk about evil drug companies. You could tee off on that, Bob. But I just want to say a minute about your example about the cell phones. If you found a way, the book focuses on something that people haven't talked about enough in the health sector. There's a lot of focus on prices. There's a lot of focus on access, right? But there's very little, or relatively little, I should say, assessment of how innovation happens in this sector and whether we're getting the right stuff. And if a miracle should happen and everybody read this book and decide, oh yeah, the researchers have it and we know exactly what to do, and we're going to change the direction of innovation so it becomes better and cheaper, we wouldn't necessarily spend less money on healthcare. We'd probably spend more, right? Just like you're using more phones now, right? And because what a innovation system that generates better and cheaper does is it allows you to generate social value through new health, more health, right? Better treatments, better treatments is let you live longer, increase demand for all kinds of other things like knee replacements. I mean, all kinds of things like that, right? You'd probably spend more, but society would be better off, right? Right. That the goal of is not to spend less on healthcare. The goal is to use our healthcare resources as wisely as possible to make us as well off as possible. So that's philosophical. Bob, you could talk about evil drug companies if you want.
Thank you very much. When we talk about markets, it's less about evil drug companies. It's more about what are the incentives to adopt new ideas. And it's a longstanding debate in economics, right? Do monopolists innovate faster than firms in competitive markets, or do monopolists innovate slower by virtue of the monopoly position? It's gone back and forth. And the sort of thinking that we adopt is related to something called switchover disruptions. And that is monopolists, which is most healthcare markets, certainly for insurance and for hospital services, which are the important ones, setting aside drugs for a moment. Most monopolists will innovate more slowly if there's a lot of switchover disruption. In other words, when the world switched to minimally invasive gallbladder surgery, that took about 48 hours, right? And that was a huge sea change. But the switchover disruptions weren't that high. Power relationships didn't change. A surgeon was still a surgeon. It was all good stuff. Electronic medical records, a whole different story. It was a matter of decades. And there, the switchover disruptions are quite high because, are you turning doctors into clerks? Are you touching every aspect of the clinical system, et cetera? So what we say is that for innovations, important innovations where the switchover disruptions are high, monopolized markets like the ones in healthcare will be slow to innovate, and they'll sometimes simply avoid innovation altogether. They're happier raising prices and living the life they know rather than taking chances on innovations that are threatening. Does that answer your question, Matthew?
Yeah.
Okay.
Can I add something to that?
Yeah, please.
Real quick, which is Ian talked about ChatGPT, right? And that the CEOs are really worried about it, or they're trying to wrap their arms around it, right? Because it promises to both improve and to change their world, right? And they're trying to, and so Bob and I have been thinking about this a lot. We're actually writing a short piece about it, which you'll see somewhere soon if anybody ever accepts it. But the
healthcare blog is a very low bar, by the way.
Right. Right. That was our first choice. Okay.
You're on our list, Matthew.
Yeah, that's right. You're on our list. And he means that in a good way. But if you think about it, ChatGPT, if you buy our story of switchover disruptions, that certain technological changes really disrupt business as usual, and that for profitable monopolists, that's a very costly disruption. And they'll often avoid it, right? But in other areas, it doesn't, right? That you have to think, when you think about what's going to happen with ChatGPT, our story says the spread is going to be less than you'd hoped and more uneven than you'd hoped, right? Even though it has it may have this transformative potential, because it will be slow to be diffused in areas where there's a lot of monopoly power and a lot of switchover disruptions. Where, for example, doctors believe that their hard-won expertise is going to be replaced away, you're going to get a lot of switchover disruptions. On the other hand, if you could make the case that what ChatGPT will do is complement their existing expertise or make their nurse practitioners much more powerful assets in delivering care without driving themselves nuts, and better care without driving, well, then that'll be smoother. And so in thinking about ChatGPT, our story about monopoly and diffusion of technology says it's not enough to think about the wondrous things these technologies should do. One should also think about the organizational disruptions that they bring with them and think about ways to mitigate that.
So the line of the week on ChatGPT comes from Kim, who said that, to get it right, Kim, he said that AI is going to be ready for healthcare a long time before healthcare is ready for AI, which is probably about.
The problem is, I think we're going to have no trouble finding uses for AI, and it may make care better and cheaper. The trouble is, we don't pay for better and cheaper. We pay for more.
Yeah, that's right. That financial incentives. So let me dive in, because there are
just one positive sign that maybe aligns with both the theory and the practice and the observation there. I mean, The example I've come across is Houston Methodist recently, because it relates to a company I have an advisor to, a private equity company working with the AHA. Anyway, the use case of ChatGPT enabled technology to essentially go into Epic, extract a 2-sentence summary, and build it into the workflow. And the punchline was give back to caregivers up to 30 minutes per shift per caregiver.
Right.
That's an example where the norms, the value, and the incentives sort of align perfectly. But to Kim's point, there are lots of other places where if you had thrown that in and say we'll get rid of all the radiologists, you'd have a fight in your hand. And I've always said from the beginning of this conversation about AI is that AI will end up being hamburger helper for doctors, and then everybody under 40 goes, "What's hamburger helper?" Even my metaphors are too old.
Let me bring in a couple of things that were mentioned right at the start here, because this I think is sort of down to it. And I've always been kidding about how the recent, over the last decade and a half, we've now developed a whole bunch of hedge funds who do healthcare services on the side, and therefore have not only a lot of little incentive to change as monopolies, but a lot of money to lose while they decide not to change. Not that they didn't take the government's money during the pandemic to stop it. But to be fair, Ian and Jeff Goldsmith's not on this week, but wrote a great piece about how actually, we beat up, people like me were beating up on health systems too much, but if they hadn't been around to deal with the pandemic, things would have been much worse. But Robin, you and Jane both mentioned two things which are screaming big deals. So I want you to talk a little bit about them and say how you think they're playing out. So Robin, you were talking with Bioformis, who, as far as I can see, you're doing, got $500 million of who knows whose venture capital money to do a lot of stuff, but a lot of it's hospital at home. A lot of it is building programs for a lot of it was, I don't know how much you impacted this in the conference. A lot of it was building programs for different conditions at home, and sending a lot of technology into the home to patients as well, kind of patients quote unquote like you. And then Jane, you're talking a lot about retail, and there's the big picture of retail, which is all my friends on the 4th of July drinking and smoking weed and skiing to excess. I guess the skiing might have been good for them until they crashed. But I mean, a lot of other stuff we know ends up in behaviors which are not good for the healthcare system. But also there's the role of the retail players as disruptors, the Walmarts and the Walgreens, and CVS is getting into the world. So I'd love you two to opine a bit and sort of, say how you think that's gonna play out on either of those sides, given what Bob and Jim just said. Either one of you go first. Start sharing.
Well, I can start. I actually was captivated by the chapter of the book, Missing Innovations, and the discussions about slightly worse but cheaper interventions. Because I think people optimize as best as they can in daily life, whether they shop at Walmart or Nordstrom, or whether they are enrolled in Medicaid or Medicare Advantage. I mean, people have the information at hand, the money at hand, and they optimize as best as they can. And so your dichotomy, Tesla versus Toyota, really rang true with me, because I think that's the real world that a health consumer, quote unquote, lives in. The consumer, again, I use in terms of paying out of pocket. When things are shoppable, they're shoppable, and people try to shop around, including finding convenience, access, cultural access as well. That's why some of us shop at Walmart, some at Nordstrom, whatever. So I think that chapter really, that section resonated with me. And then, of course, you had me at Victor Fuchs.
Yeah.
For the wonks in the room who study health economics. But I think that's so relevant right now, taking the patient's lens. And I was in a room last week with a big pharma talking about the value in the eye of the beholder in terms of specialty drug co-share payments.
Yeah.
And, Mrs. Jones's endpoints are different than the R&D folks at pharma and what the FDA is looking at. Mrs. Jones, I always talk about Mrs. Jones and Mr. Smith. She wants to get on the floor with her grandchildren and play after she survives her cancer. And, Mr. Smith standing at the barbecue on July 4th, etc. but the endpoints for them, the qualities for them are different than the qualities for NICE or
Right.
ICE or whoever.
Yeah.
So what I'm trying to, and I love what I read of the book. I read more than half for sure. And it's so exciting, because this is the world that lots of us live and work in. But it's like, how do we get the patients and the consumer and the caregiver and the families involved in the value discussion? Because they're making the decisions whether or not we get them involved in the discussion. So I think we've missed out, though it's getting better, and that's where I'm spending a lot of time now, is rounding out the stakeholder communities. And that's why I like the retail angle so much. It is what it is. I'm not saying it's perfect, but today that's where we can make an impact in 1-3 years,
So Jane, if I could build on what you said for just a second, I think I think you're right that this retail dimension, because it takes the confounding effects of insurance out of the decision making in some way, so it's kind of like a real commodity, a real service that you're buying. And I think in healthcare, the role of the doctor is really important, even in the sort of retail-like setting. And like an example that really one of our colleagues recommended to us and really resonated with Jimmy and I had to do with the COVID-19 rapid tests as a real life example. And for a long time, because the tests are slightly worse but much cheaper, doctors didn't know what to make of them.
Yeah.
And patients struggled because their doctors struggled, right? And so everybody was confused, and it took us a really long time as a country to begin to make proper use of the rapid test. And I think that's an example of how doctors and patients together, all of us are unused to slightly worse but much cheaper innovations in healthcare.
Bob, just an addendum to that example, which I think is a great one, is that it actually turned out, if you believe the work of Michael Mina and other sort of experts who sort of synthesized a lot of the science to say, if you test positive in a rapid test, you're probably contagious, right? Which is actually the thing you want to know, right? So it actually turned out to be a better product than a PCR test where you'd be positive till, the next decade because it's looking for, one molecule.
Right. Yeah.
And that's a sort of an alignment where the interests are lined up. It answers the question you want to, what's the job to be done? That's the job to be done, right? I don't want to infect somebody else. Not hypothetically how many, molecules of this stuff do I have in me? Anyway.
I think that's exactly right. Yeah. But I think I'm really glad you raised that, Bob. But Jane, I want to add two things to Bob's answer, and I think what the points you raised are really important and interesting. First is there's actually been a lot of work recently in some really good health economics about how people react when they're put in the position of shopping, and it turns out they react not so well. They don't make such good decisions. They're strongly influenced by whatever their physician recommends. Comparison shopping is, if you think that you just sort of give consumers an opportunity to save money by making better choices, you'll be disappointed. They need a lot of social infrastructure around that, including as providers who kind of sort of in a position to help for them to make better decisions. But I think the problem is even harder than that, because when you started off, you were talking about Weight Watchers and collaborating and Abbott, right? And there's a very deep incentive problem in that really shapes involved in those kinds of interventions. I think really shapes their ability to get traction in the healthcare system, which is that a lot of the investment in that kind of thing generates returns 2 decades down the road. And the healthcare system is incredibly badly designed to capture future returns. There's an enormous amount of churn amongst insurers. People don't stay in their jobs that long. The U.S. healthcare system is poorly designed. We don't stay in our jobs very long. We shouldn't. If we have a well-functioning labor market, people should leave for better jobs. But also, employers don't stay with their insurers very long. They're always churning to find sort of a better deal because the market doesn't work very well. And so there's always the opportunity to find a better deal. And because of that turnover, investments in somebody controlling their diabetes now turns out to be somebody else's game. In fact, I remember years and years ago, long before Bob and I started this book, talking to a healthcare consultant who said, I don't see why we treat any diabetics, right? Because every dollar I spend on that is saving Medicare money. Why am I doing that?
That's what I was going to come up, right?
Yeah.
Everyone gets done from the government at the end of the day.
Yeah. So like
the end.
That's right. And smart people have tried to invent different kinds of fancy contracts. But basically it's very, very difficult in an employer-based system, and particularly one where there's so much insurance churn for innovators, for insurers, payers to capture the returns, and consequently for innovators to make money selling these things. And we think that that's one of the incentive problems that biases the direction of innovation in health system away from the kind of things that were captivating to you.
Well,
Yeah, and
Jim, there are. Oh, sorry. Yeah, can I just jump on here because it's a point.
We never got to Robin's.
Yeah, well, there's two, Robin. I was going to ask Robin about bioformulation and all that system structural stuff, but given Jane took this towards patient choice, and Jim said, hey, it doesn't really make any difference to patients. And Robin wrote a book called Patient as the CEO. I'd love to hear your response, Robin, to whether you think Jim's full of it or it's true, or what can be done around that issue.
Well, yes, I mean the employee-driven stuff. It's kind of hard to integrate into, but I kind of look at some of the big payers and what they're doing in the Medicare space, because that's where a lot of dollars go. And so United has spent over $12 billion in less than 2 years buying in-home companies that provide care in home. Humana has done the exact same thing, as well as CVS, Aetna, and then companies like Bioformus. They provide that platform for both clinical trials at home, but also hospitalization and remote patient monitoring at home. And so let me tell you why this saves so much money. So like I've been on Remicade for over 23 years now. First 15 years, I got it done in the infusion clinics. My hospital was charging $28,000 just for the medication every single time. And I get a tiny dose. I'm only about 40 kilos. And so there are patients that get 2 to 3 times the amount. And it's usually, every 6 weeks is when I get mine. My insurance company about 7 years ago said, hey, you want to stay on Remicade, you're going to have to get it done in the home. And first of all, it blew my mind that I could do that in the home. I was so incredibly excited, but it dropped the price from $28,000 to $2,500 over a 5-year period. That comes out to a difference in billing of over $1 million, right? 2% of the country's population are on specialty drugs like Remicade, and that makes up for more than 55% of all drug spend. Right. And so looking at those Medicare patients, looking at those top 10 drugs and how much those cost, shifting that into the home can save significant amount of money.
Yeah, we're with you on that. That's a great story, Robin. One of the things that interests us, and Jim, I'm going to hand the ball to you in just a minute on this, is
Please don't.
one of the things that really interested us is we think there's enormous, hospital at home is phenomenal, and it's been studied since the 1970s, and Bruce Leff and his whole cadre of social entrepreneurs who are trying to make it happen have done us all a great service. One of the things that interests us is why it took a couple decades to get to this point. Why did it go so slowly? And it only moved when Medicare moved. And we have a pluralistic, largely private system where one of the virtues is the private payers ought to be able to move faster, right? They ought to be the innovators who are driving Medicare, not the other way around. So that's one of the questions that we have been. Jim, do you want to give the answer, or shall I tell the story? What do you want to do?
Oh, this is a hard question. Go ahead.
Okay. So what the thing that we think about is from the perspective of the private insurers, there's a lot, it's a collective action problem, right? every insurer is trying to get a set of hospitals to do the best thing to be as affordable as they can. And taken together, it would have made a lot of sense for them to invest earlier on in these sort of programs like the one you described, because it would save everybody a lot of money. But there are a lot of upfront costs. And nobody wants to be the first guy to take on those upfront costs because it benefits all the other insurers. So they wait, and they wait until the big insurer makes the move for them, and then they can follow along. And that's one of the paradoxes of our system, and is that the private players who ought to be the innovators, when there's a lot of upfront and big change involved, will often wait. You see the same thing happened with DRGs. Why was it Medicare that came up with DRGs and not United Healthcare? And the reason was they wait around until the big player moves, because the benefits leak to all the others, which reduces their incentive to act. So
yeah, and at one level, a lot of these issues we're talking about, the very important points you made about churn, and this point, Bob, about the benefits, the collective action problem, are endemic to the American system. It's the price of pluralism, right?
Right, exactly.
Right. That's exactly right. That's exactly right.
I'm sorry, Jim, go ahead.
When we were writing this book, one of the things that Bob said to me over and over again is, remember, Jim, every time you use the word externality, we lose 10 readers.
No, I said 50%. 50% of our readers.
No, you said 10 readers and we start off with 20. And so, since my brother introduced the term a public goods problem or public and coordination problem, I feel emboldened to give you the economic terminology for the particular problem he was outlining, which is a common agency problem. When you have a lot of principles trying to influence the common agent. Here it's the payers are trying to influence, a bunch of payers are trying to influence a single hospital or a single provider. And that's what creates these issues.
A couple of comments on.
Oh, sorry. Go ahead, Kim.
A couple of comments on insurers, having worked for several over my lifetime. So first, you talk about the churn. You have to remember that over 50% of health insurance in the U.S. is self-insured. So even if they change their administrator, it's the same employer getting the same savings. So it's more the employment churn, not the insurer churn, that's really the concern there. The employer is always going to be the one that gets or doesn't get the savings over the long term for self-insured things. And second, when Bob was talking about the innovation, there certainly have been a lot of innovations that came from the private sector, capitation, managed care networks, and so on. The thing with something like DRGs is it's very, most insurers have relatively small market share in any given market. So it's hard for them to come up with a radical change in payment if they're just, 5% of the market.
Exactly.
Whereas Medicare, if they do something, everyone's going to do it, and then you can jump on. So a lot of it's, are you the tail or are you the dog? And in most cases, they're the tail.
But I would say that, Robin's point is that a lot of the stuff's happening in Medicare Advantage, and George Halverson is frequently writing on THCB explaining how Medicare Advantage, fixes all the problems for Medicare. The service has, and that's because of competition amongst the plans, etc. And we go back and forth on the gang about whether this is shoved down to the medical group level or whether it's up at the plan level. Whether this is really happening or not, is it really saving money but putting all those arguments aside, you've seen a ton of investment capital. I pick on Bioformers because Robin was there, but what are they raised, $600 million or something ridiculous? I hope they can pay your speaker thing in full, Robin, is the important thing. That's the most important use of investment capital. But beyond that, there's a lot of people who are now standing up the quote unquote solutions that you could bring. So some of the cost of doing this stuff, it's like getting a taxi in the last few years got a lot cheaper because the venture capitalists paid for half your Uber fare, right? So I think you could argue that there is stuff out there that you can now introduce from all the Silicon Valley, Health 2.0 crowd going forward. The question is it making, what's the level of impact it's going to make things better and cheaper? So, let's pick on hospital and home as an example. It theoretically, Robin's an extreme case of drug price reduction, but there is good evidence out there that it saves money. But do we just end up using more, like the British steamships the British Navy steamships in 1900, or what is actually going to happen as an impact of this, or is it going to be a sideshow the way it has been for the last 30, 40 years?
So I learned, I talked to one of the SVPs at Bioformus when I was there giving their keynote. And she told me a story about a 79-year-old man that they do remote patient monitoring on. And he's, really high energy and boisterous and loves talking to the nurses on video. And then he started showing a low heart rate. Typically, a patient would not know in their own home that they're getting a low heart rate. And so Bioformus knew immediately. They adjusted the meds, and that helped a little bit. And then they started seeing this low heart rate as well. And he wasn't quite as boisterous and lively as he had been. So they had made him go into a clinic and be seen, physically. And it turns out he needed a pacemaker. Typically, a patient like that, they're getting dizzy and confused because their pulse is way too low, and they end up breaking a hip, which is, a catastrophic injury at the age of 79. And so really thinking about how much money they saved the healthcare system, and they may have saved his life, right?
Just to tie this to the conversation I had with these CEOs this morning, even though the incentives are not aligned, and we've talked a lot in the gang about, we behave, and our PowerPoint is that we're all going to be capitated, when in fact 7% is effectively capitated. And what I've been trying to pitch with CEOs is do things like hospital at home or social determinants or partnering with retail, Jane, do it out in the name of throughput, because you're busy anyway, right? Even in a fee-for-service model, not so much because you're capitated, right? So I think we've got to get the incentive right. And I've been trying to change the narrative with them. Like, I accept the fact that you have zero capitation, but you should be doing this thing anyway because it's better for patients. And you're going to release resources for other purposes on a fee-for-service chassis. And it goes back to what Jim said earlier, which is very wise, which is, better, faster, cheaper doesn't mean total spend goes down. Because I think that's part of the problem, and as a recovering health economist that we all have, which is...
I thought you were a geographer.
Yeah, well, it's the only thing I'm a legitimate...
Right.
Jane's a legitimate health economist.
Do we have the product right? Because I think we underestimate. It's like that chart that shows the prices of hospitals going way up. Are we talking about the same thing over time? I mean, I had bypass surgery back in December. Now, I would love to have had the cheaper and not quite as good angioplasty. In fact, I was in the middle of it when the guy said, "Time out. I'm not putting the 2 wee stents up through your wrist. You're going for bypass surgery." I would have preferred the former, let me say, to the latter, but I wasn't given any option in that, right?
Right.
So my point is that the product changes, right? And I think that's why Robin's focus on those very, very high cost cases. Now I am one. I appreciate, but I think trying to figure out whether or not we've innovated tremendously and the product has changed as a result, so it doesn't look quite the same as before. And it's your point, Jim, about total spending on communications through mobile devices has gone up, not down,
Right.
But the unit cost of lighting has gone way down, right?
Right.
Well, one thing I'd like Bob and Jim to talk a little bit more about is there's sections on the norms, because it strikes me that a lot of our clinicians have gone from being about the patient to about who owns them or who bosses them or how they're going to get paid or whatever, and it's destroying the profession and it's not helping the patient. So how do we get back to that norm being like what drives our healthcare system?
Jim, do you want to jump in, or shall I jump in?
You go ahead.
Kim, that's just a fantastic question, and it was one of the deep interests we had in trying to write the book. We think that the medical profession and nursing and the allied provider professions are at the heart of making things better, and it's recapturing and reinforcing that sense of professional pride and professionalism, and also augmenting it, making it a little bit bigger. Because right now, the physicians are trained in how ethically and philosophically in how to think about themselves as advocates for their patients. And we think that they have a dual role. And the second part, they're not educated and exposed to by and large. And that is, they're also stewards of social resources. And how to operate in that ethical environment is something that they don't get in medical school. And if they join the Kaiser Permanente system, they learn about that because they have to learn to do that balancing act, particularly as they move up the leadership ladder. But it doesn't, by and large, it's off the radar screen. And so it makes it very hard for them to employ their ethical commitments on behalf of patients and society in that way.
And that matters a ton for the direction of innovation, right? Because the way our innovation system works, the direction of innovation is driven by anticipated returns, and the system is set up largely so that returns only occur when the innovations are used. And if you don't have a set of innovations that align with the self-conception and ethical concerns of the providers, it's not going to get used. There'll be enormous resistance to it. And so the norms matter not only because they're part of descriptively how people behave and what drives them, but it also has this sort of second effect which is if people don't see an ethical obligation to be stewards of the social resources to deliver care, their interest in things that may reduce the cost of care is going to be much reduced. And in fact, there'll be maybe a lot of suspicion of it, right? As introducing inappropriate pecuniary motives into a setting that should be pure of that should be, but before we leave this, I got to say one more thing. The thing you said before about turnover in insurance markets, you're exactly right. Right, the big churn of the self-insured employers, that's not relevant for they could capture a lot of future returns, but for the labor market. But for the small employers, it's a big deal. It's a big deal because also they don't shop very well. They're sort of at the mercy of their agents, who are kind of not great agents for them, right? Who don't, they get side deals and all kinds of stuff like that. So you see a lot of churning because of bad matches and things in the small group market. But you're right, it's not a problem for the big group market, for big. So I just wanted to say that I think you hit it exactly right.
Other than they may buy through PBMs, which they don't understand. So I'm not so convinced about that, but Jane, jump in.
Yeah, so I want to go back to the importance of the clinicians, because people do trust and love their clinicians, just generally speaking. And in a special shout out to nurses.
Yes.
Because nurses know how to hack and innovate on the fly. They're out there in the front. I've had a lot of experience the last few years working with nurse hackathons. And it's amazing, nurses coming together from all over the world to co-create, because they know what they know, right? And to double down on this, as we know, year after year, our great friends from Gallup poll survey honesty and ethics in professions. And it's always, for the last decade plus, nurses, doctors, and pharmacists. Always nurses at the top, pharmacists and doctors switch off. But nurses are so key, and our doctors, of course. And if I'm totally with you on this, the power of the patient and the clinician. And we can't lose that. We've got to build on that and value it. And I agree with you. That is where the social ROI is going to happen, must happen. That's what patients want, and that's what clinicians want. And it's a win-win. So we need to support them with our, quintuple aim heads up.
Yeah.
Yeah, that's a great point about the role of the professions. I would say that, if you just look at the US, most of the news stories I follow are not about, how we're uplifting professions. They're all about how PE companies are coming in, taking over, charging more, doing stuff that, and the pecuniary motive is right in the front. And, Robin, when you and I hang out a lot with the innovator crowd, there's a lot of doctors who take roles in those companies, many of whom are doing it for great moral reasons, and a lot of doing it because they can get much richer there than than staying behind in the systems, practicing medicine. I want to switch, gents, to, we've got about 10 minutes to go. So a lot of the problems that you discussed, I mean, you threaded them together in a beautiful way, but have been commonly talked about over the years. We know incentives are screwed up. Reinsurance has been a problem. We know that there are issues with the interests of monopoly players. You've infused this with the norms and narratives, which is a very interesting way. And I think in the discussion about competition, how are we going to fix this? And what are your suggestions, policy options? Suggestions for either individuals, policymakers, corporations, whomever in healthcare. What do we do? What's the sort of the output of the book, rather than rather than just another book about how healthcare is screwed up in 78 different ways, and we're never going to fix it. It's too big and too complicated.
So, Matthew, on top of everything else, you want answers? Is that it?
Yeah, that's basically it.
Right.
I wrote a very brief piece the other day about how Ian, when I started hanging out with Jay mentioned Vic Fuchs and Alan Homan and Ian 30 years ago, I assumed we were going to a capitated system based on universal coverage.
Yeah.
And somehow we didn't get there, and it didn't get better and cheaper on the way.
Right.
So now you get the chance to fix it.
So if I could just start, but I think you should take
please.
it. You should take it further. I'm going to say something that I think is not happy but helpful, which is there's no silver bullet. We have no one thing, get it. The sort of economist mantra, get the prices right and everything else will kind of work. And they usually mean by get the prices right, get the incentives right and everything. Our stories suggest that's not at all adequate or sufficient for reforming changing the direction of innovation. And so we have a kind of a long chapter full of ideas. And do those ideas work into a coherent policy? I'm not sure, but they might inform some of the really important work that Robin's doing with what's called ARPA-H, which I'm really intrigued by. I would love to learn more about. I think that it could be just it's the kind of thing that could make, with the right lens, could make an enormous difference. But we divide our answer into three parts. We talk about ways to better align the incentives of the patent system with value creation, right? And by value creation, we mean social value, not just willingness to pay kind of stuff that we teach our MBAs. We talk about ways to shift the rewards from innovation in the patent system away from one of the great things about the patent system is that you only make money on a new invention if people use it, right? So it has a built-in market test, which is a good thing, but the market tests can be screwy. And we talk about ways to sort of introduce other kinds of mechanisms. We could talk a little bit in more detail about that if you want, to reduce some of the distortions introduced by the market test, and also some of the distortions introduced by the fact that patents give monopolies, and monopolies are generally bad things, not good things for social value. And then the other set of ideas we have are ideas about how to make it easier to make money from cost-reducing innovation. So there are fewer of those that go missing. And we have a lot of details, most of which we cribbed from other people's proposals. But Bob, you want to build on that?
Yeah. So one of the ideas that we talk about is the idea of jump starting. So we talked about hospital at home, and it gets all kludgy because nobody wants to make the first move. And so what CMS did when it approved the temporary waiver for hospital services at home is it jump-started the innovation. And a jump-starter, it doesn't have to be the government, but to Kim's point earlier, it does have to be somebody who has a lot of market share on the relevant providers and patients. So that could be a narrow network payer in a narrow network. It doesn't have to be necessarily an integrated payer provider system like Kaiser, but somebody who has a lot of influence can do that. So you need to look for jump starters to get over some of these incentive problems. Sometimes it's the government, but it doesn't need to be, but you have to think about it very tactically to think about who's the right jump starter for this innovation in this place, in this time. Another thing that we can do as a society is that part of what makes cost reducing innovation really hard is that there's no infrastructure for it. It's a special project every time anybody wants to figure out what something costs. And you have to sort of assemble a team of accountants to do cost accounting and a team of computer engineers to figure out how to collect the data. And then you have to develop one-off agreements with 10,000 different parties in order to collect the data. And so it's just really hard to really have the data that allows you to know if you're really making an impact on cost or not. And so investments in that infrastructure would be a very powerful thing to do. And then another thing that we think is really important is in medical education, that we need to be able to teach doctors how to engage in innovative activities, how to play both roles as patient advocate and social steward. And there are examples, there are lots of good examples out there, but every medical trainee gets some time to do scholarly work in some field in this, sometime in the course of their specialty training. And very few of them are picking to do work. I mean, normally they work in a laboratory. And we think there ought to be more opportunities for people to work as engineers and as innovators. The Stanford Biodesign Program, the Stanford CERC program, there's some interesting programs at Texas A&M University where they're teaching engineers, physicians to also work as engineers. And there needs to be more of that. That needs to be part of how we train doctors. And then there's a philosophical dimension to all this. It's as long as we live in a society that's really ambiguous about the nature of medical care, it's really, is it a social good or is it a private good? And America hasn't decided. This is Uwe Reinhardt's great point, is that because we haven't decided, we're all over the place. We can't figure anything out. So from an ethical perspective, we need to decide what kind of good we're talking about here. And if it's a social good, then it's much easier for physicians and other providers in the system to play a positive role. And if it's a private good, we're in kind of different territory. But there's a sort of ethical, philosophical foundation that makes all these technical fixes complicated. So Matthew, this is something tomorrow we have an act of Congress and it's all done. So,
well, it helps with the act of Congress is pushing the ball down a hill that's already rolled down. Like the Inflation Reduction Act is doing with clean energy, and I don't see the ball. I didn't see the hill, let alone the ball running down the hill. Yet. All right. So to wrap, what we're going to do is have a quick go round of our four regulars, and then I'll come back to Bob and Jim. But just for your comments on what we've been talking about today, how you think you're doing, and whether you think we're going to be better and cheaper, or what our hopes are. Jane, why don't I start with you?
About what I'm looking at?
No, just in general, what you've thought about this discussion and whether you think we're going to be better and cheaper.
It was such a great discussion. I love the Flying Rabbits are twin brothers. They're so great. It was a joy to spend this great time with all you smart, wonderful people. And we all have work to do on this. I mean, as the Rebbitzers say, there's no silver bullet. But I think if we keep focusing on the ecosystem and building bridges across and thinking out of the silos, we can solve this. But it is, to Ian's point, and I believe it, what is the product anymore? When we think about Robin and home care and home dialysis, like what is that? It's a new world now. And so this bridge to telehealth, it's just health. And it's changing the nature of health care. So I think that's what I'm going to wrestle with for a while.
Thanks. Kim.
So Jim and Bob started out with talking about the cell phone analogy. So I want to use my own cell phone analogy. To me, the greatest innovation in cell phones was not the increased computing power. It was not, the BlackBerry or the iPhone. It was not the killer apps. It was in 1998, AT&T said, we're going to go to a flat rate per month. That's it. Before that, you paid local, you paid long distance, you paid roaming, you paid data. You had never had any idea how much your cell phone bill was going to be. They just said it's $100. That's it. Do what you want. Without that, none of the other things that have happened since then would have happened because we would have been worried we were going to put a $10,000 bill. So that's what healthcare needs.
Yeah.
And they bundle it, and when the iPhone came out, they bundle it, the cost of the iPhone with the phone plan as well. It happens AT&T as well. Good call. Robin.
So I started adding generative AI to my longer 60-minute keynotes on artificial intelligence. And that company I went to a couple of weeks ago, Advanced Medical Solutions, AMS, they've already incorporated generative AI into really figuring out those most expensive patients and really how to start mitigating those huge bills. And so it's an incredible time. And I'm going to keep my eye on the new generative AI stuff going on for price lowering. Yeah.
Better and cheaper, and also sometimes wrong, but that's a separate question. Ian, let me give you a final comment and we'll go back to
I just, I appreciate Jim and Bob being available. This has just been terrific. But I would say, and I've had a chance to skim the book now twice. Speed reading twice is almost like reading it, right? But I actually think, and I appreciate your synthesis of suggestions and resisting the temptation of all you have to do is fill in the blank one sentence. But I do actually think, and there's maybe a follow-on article here for you, which is around using, because you've, I think, brilliantly brought together and synthesized the kind of intellectual framework of the problem and almost turning it into a dashboard. I'm thinking particularly for health system leaders about how to parse innovation. And when we had that discussion around the rapid tests, that was a thing where everything lined up, but often they don't line up. So I would urge you to think about almost like a consulting innovation, Bob, of what's the template that you draw from the literature in terms of these various factors. I spent a couple of days with an organizational theorist from University of Michigan last week at this meeting, who's an expert in kind of the behavioral social psychology side of innovation. And, those kind of toolkits and templates of, design thinking, which I know you're very familiar with, are helpful as a practical translation decision makers. So maybe there's a follow-on is saying how to bring kind of a design thinking to that apparatus, the intellectual apparatus that you've dissected so well. Because I think it is highly nuanced, and that's why we haven't made as much progress, because it's tough stuff to try and move big complex systems with massive inertia, and it matters because it's not like, when my son worked for Bleacher Report, they could innovate. The world is not going to end if you write something bad about Steph Curry, but the world can end if you screw up cardiac surgery, right?
Yeah, that's right.
Anyway, well done, guys. It was a great contribution.
Thank you all. I learned a great deal, not only about the healthcare system and about you all, but about our book. So thank you.
Well, so the book, and I've got the hopefully sharing this now. Book is Why Not Better and Cheaper: Healthcare Innovation by Jim Bellard and Bob Robertson. Gents, thanks very much for coming on our show. I will just wrap here by saying, as ever, I screwed up again. As ever, I screwed up again. That's not what I usually say, but that is what usually happens. As ever, you were listening to and watching, depending whether you're listening on the podcast later or capturing on video, to Kim Bellard from the wilds of Cincinnati, Ian Morrison and Robin Farmanfarmaian, both from the Silicon Valley. But I think Ian's slightly north of Robin in Menlo Park, in Palo Alto. But we've got very Californian with me these days up in Tahoe. Jane Sarasohn-Kahn, late of Belgium, but now back in the US in the Pennsylvania region. And our special guests were Bob Robertson and Jim Robertson. Bob, you live on the West Coast, and Jim, I assume you live in Boston, or you've been telecommuting to Boston University Business School. So the office of Why Not Better and Cheaper. THCB will be back again next week, a whole different gang. So please come and watch us and listen to us there. But for now, thanks for watching, thanks for listening, and I hope you enjoyed this. And again, go out and buy the book. It's available all good bookstores or Amazon right now. And with that, we'll say bye for now.